What's a skeleton's favorite? So if anyone's gone into my courses, and if you happen to click on the Zoom tab, you may have noticed that I went ahead and just scheduled a repeating Zoom session for every lecture for the remainder of the semester. Seems like the last couple of weeks, just about every lecture, somebody's asked if I could Zoom it because they're out sick or have some other reason to miss class. I also know we have at least one person who's missing a couple of weeks of class. So I figured, all right, may as well just go ahead and Zoom them all, and may as well record them. I mean, if I'm Zooming anyway, I may as well record them so that those recordings will be available to you in the future. So this one is being recorded now. So I assume you'll be happy to know that we're done with the head and neck, and we're moving on to something new, which I always enjoy the dissection of the thorax. For the most part, the structures are relatively large. For the most part, they're larger than all those little tiny nerves and things that we're looking at in the head and neck. Many of the structures actually really look like the pictures, like the heart and the lungs actually look like the illustrations for a change. Whereas oftentimes, you know, muscles and nerves and arteries and veins and things don't necessarily look very much like the pictures. All right, so as I do whenever I introduce a new region of the body, we're going to start off with the skeleton. We're going to start with the bony framework, and then we'll add the musculature, and then nerves, arteries, and so forth. And with the thorax, then we'll get into the internal organs of the thorax next week, the heart and lungs, and so forth. All right, so the bones of the thorax, of course, include the thoracic vertebrae, which we've already talked about a little bit, but I'll come back and revisit those a little bit in today's lecture. The ribs, of course, you know, which make up most of the bony framework of the thorax and completely surround and enclose the thoracic organs. And then anteriorly, also the sternum, different parts of the sternum. We also have the costal cartilages, which are pieces of cartilage that connect the anterior ends of the ribs to the sternum. And the ribs are divided into three different groups: the so-called true ribs, the false ribs, and the floating ribs. I have to tell you, I've never liked that nomenclature. I've never liked that terminology, because all of these things are perfectly good ribs. False ribs are not, there's nothing fake about them. I mean, they're just as much a rib as the true ribs. The distinction between these three different types of ribs is based entirely on the configuration of the costal cartilage. So it really has nothing to do with the shape of the rib or the location of the rib. It has everything to do with the orientation or configuration of the costal cartilages attached to those ribs. So I almost feel like we should use different terms. Instead of calling them true ribs and false ribs, we should use more descriptive terms that actually describe their costal cartilages, instead of, you know, making one group of ribs sound like they're real and another group of ribs sound like they're not real. But this is the terminology we're stuck with. This is what anatomists call them. So the first 7 ribs, ribs 1 through 7, are known as true ribs. And the thing that distinguishes them is, if you look at any given rib, we'll look at the second rib here. The rib attaches to one of the thoracic vertebrae in the back, and then wraps around the side of the thorax and comes around towards the front of the body. And it has a costal cartilage that goes directly from the tip of the rib and connects it directly to the sternum. And if we go all the way down here to rib 7, which is the last of the so-called true ribs, we see the same thing. That rib wraps around towards the front of the body and has a costal cartilage that connects the tip of the rib, where'd my cursor go, directly to the sternum. The false ribs are ribs 8 through 10. They also wrap around towards the front of the body They also have costal cartilages. But if you follow the costal cartilage of rib 8, for example, you follow it up, you see that the costal cartilage of rib 8 does not connect directly to the sternum. Instead, it connects to the costal cartilage of the rib above it. So the costal cartilage of rib 8 is connecting to the costal cartilage of rib 7. So the 8th costal cartilage does not go all the way to the sternum. It stops when it joins the cartilage of 7. The same is true for the costal cartilages of ribs 9 and 10. The 9th costal cartilage comes up and joins cartilage number 8, and the costal cartilage of rib 10 comes up and joins the cartilage of 9. So the ribs themselves are identical to the true ribs. It's the only difference being that the costal cartilage does not connect directly to the sternum, and instead it just connects to the cartilage immediately above it. Finally, the last two ribs, ribs 11 and 12, are known as floating ribs. And a lot of people think that the floating ribs do not have costal cartilages because you see they're not connecting to anything. But ribs 11 and 12, the floating ribs, actually do have costal cartilages. You just have to look very closely at the slide, and you'll see that at the very tip of the 11th and 12th ribs is a tiny little blue tip. Looks like a little blue fingernail on the end of those ribs. That is the costal cartilage. But those cartilages don't go anywhere. They don't connect to the sternum. They don't connect to the cartilage immediately above. It's just a short little tip of cartilage at the end of the rib that just stops. So they're called floating ribs because, in a sense, the ends of the ribs or the costal cartilages are just sort of free floating in the posterior wall of the thorax or abdomen. Looking in a little more detail at the sternum has some important landmarks. At the superior edge of the sternum is a shallow, rounded indentation known as the jugular notch, or sometimes simply called the sternal notch. There's also a joint that's formed between the upper part of the sternum, known as the manubrium, and then the rest of the sternum, called the body. There's actually a cartilaginous joint in there. And this point where the manubrium connects to the rest of the sternum is known as the sternal angle. And then finally, down at the inferior end of the sternum, we have this small extra little projection that extends down towards the abdomen. This is known as the xiphoid process. If you look earlier in the embryologic development of the human, the sternum actually develops as a series of independent bones, separate bony structures called sternebrae. Very similar to the word vertebrae, but with sternum at the beginning, so sternebrae. And those sternebrae are joined to one another by cartilaginous discs. So it looks an awful lot like the vertebral column, where you have vertebrae separated by intervertebral discs. The sternum earlier in development consists of a series of separate sternebrae connected also by cartilaginous discs. Most of those sternebrae have fused together to form the body of the sternum. But if you look very closely at this cut coronal section where you're actually looking into the cancellous bone of the sternum, you might be able to make out that there are very faint little blue streaks. There are very faint remnants of those cartilaginous discs that are preserved, even though the sternebrae of the sternum have fused together. It's very similar to what we see with the sacrum. The sacrum consists of 5 fused sacral vertebrae, and yet if you do a sagittal cross-section through the sacrum, you'll actually see remnants of the cartilaginous intervertebral discs between the sacral vertebrae. One of those cartilaginous discs is actually completely retained up here, forming that joint between the manubrium and the body of the sternum, right where that sternal angle is. So there actually is a true cartilaginous joint there, separating the manubrium from the rest of the sternum. And that joint is somewhat flexible, and there is a little bit of flexion that occurs between the manubrium and the body of the sternum. There's also a bit of a disc that remains down here where the xiphoid process attaches to the body of the sternum as well. And the xiphoid is somewhat flexible at that little joint. All right, you've seen the thoracic vertebrae before. We talked about them way back at the beginning of the course. And just as a reminder, the one distinctive feature that distinguishes the thoracic vertebrae from all of the other vertebrae is the presence of extra facets for the articulation of the ribs. So there are cartilaginous facets or joint surfaces on the body of the thoracic vertebrae that articulate with one part of the rib. And then there are also cartilaginous facets out at the tip of the transverse processes of the thoracic vertebrae that articulate with a different part of the rib. So then let's take a look at a rib in a little bit more detail and see how it actually articulates with different parts of the thoracic vertebrae. So this is a posterior view of one of the ribs. So the most posterior part, again, if this is a posterior view, this would be the part that's closest to us up here at the top of the slide. And then the rib begins to wrap around the side of the thorax, wraps around towards the front. So the part of the rib that's shown here near the bottom of the picture, that's the part that's farthest away from us, that's articulating with the costal cartilage and then ultimately connecting to the sternum. There are several features of the rib at the most posterior part of the rib, near where it articulates with the vertebrae. There is a costal tubercle, which articulates with the transverse process of the vertebra that has the same number. Now, what do I mean by that? What do I mean by the vertebra that has the same number? If this is the fourth rib, for example, the tubercle articulates with the transverse process of T4, the fourth thoracic vertebra. Okay, so the tubercle of the fourth rib articulates with the transverse process of the fourth thoracic vertebra. Then there's a narrow neck, and then the most medial part of the vertebra, and also the most posterior part, is the head of the, of the rib. The head of the rib is the part that articulates with the vertebral bodies. Now, if you look closely at the head of the rib, you see it actually has two flat surfaces. There's a smaller superior surface and a somewhat larger inferior surface. These actually articulate with two different vertebrae. The larger inferior surface of the head articulates with the body of the vertebra that has the same number. So again, if this is rib 4, this larger joint surface, this larger inferior joint surface is articulating with the body of the T4 vertebra. The smaller superior articulating surface actually articulates just a little bit with the vertebral body immediately above it. So again, if this is the fourth rib, the larger surface is articulating with the body of T4, but that smaller superior surface is articulating with the body of T3. Okay, so the head of each rib articulates with two vertebrae. It has a larger articulation with the vertebra of the same number, and a somewhat smaller articulation with the vertebra immediately above that. And then the tubercle articulates with the transverse process of the vertebra that has the same number. So there's an example down here that, for example, the fourth rib articulates with the transverse process of T4 and also articulates with the bodies of T4 and T3. So as I said, the shaft of the rib then extends out laterally from the vertebrae, wraps around towards the front of the body, and then where it ends, it joins its costal cartilage, which then ultimately connects it to the sternum, at least in most cases. There's a feature that runs along the shaft, which is a pretty important structure. It's called the costal groove. It's a shallow little groove that runs along the inferior border of each rib. And within that groove, we find a nerve, an artery, and a vein. So below this particular rib is an intercostal space. So intercostal space simply refers to the space between any two ribs. So there would be an intercostal space above this rib and an intercostal space below this rib. The intercostal space is filled with intercostal muscles, which we'll talk about in a few minutes. And the nerve and blood supply to those intercostal muscles are traveling through the intercostal space. So there's an intercostal nerve, which innervates the intercostal muscles, and there's an intercostal nerve, artery and vein, which are supplying blood to those intercostal muscles. The intercostal nerve, artery, and vein are not running right through the middle of the intercostal space. The intercostal nerve, artery, and vein instead are actually tucked up into this little groove where they're partially protected by the rib itself. So this would be, you'd find the intercostal nerve, artery, and vein running through this groove. That would be the nerve, artery, and vein of the intercostal space that lies just below this particular rib. All right, let's take another look at the ribs and the vertebrae from a little bit different point of view, just to understand the way that the rib articulates with the vertebra. So you see that there are two ribs, labeled ribs 4 and ribs 5, that are articulating with vertebrae T3, T4, and T5. Those joints, though, are completely covered with ligaments. There's a bunch of ligaments that help anchor the ribs to the vertebrae, both to the vertebral bodies and to the transverse processes. Those ligaments hold the rib tightly to the vertebrae, but they also allow a fair amount of movement. The ribs actually have kind of a hinge joint where they join the vertebrae. The ribs can rotate up and down at these joints. But then up above in this picture, a couple of the ribs have been removed. Let's look particularly at where rib 3 would have been. And you see the third thoracic vertebra is identified here, T3. So out at the tip of the transverse process of T3, we have a facet joint. So that's going to be articulating with the tubercle of rib 3. And then there's a facet on the body of T3 that would be articulating with the head of the third rib. But then also there's a tiny little facet on the inferior aspect of T2 up above. That's also articulating with the head of rib 3. So remember that the tubercle of the rib articulates with the transverse process of the vertebra that has the same number, whereas the head of the rib articulates with two different vertebrae, the vertebra with the same number and the vertebra immediately above it. This actually there's an interesting implication to this idea that each rib articulates with two different vertebral bodies, the one that has the same number as the one right above it. Think about the first rib. It's going to articulate, the head of the first rib is going to articulate with the body of T1, the first thoracic vertebra, but also it's going to articulate a little bit with the vertebra immediately above it. So the first rib actually articulates a little bit with C7, the seventh cervical vertebra. So way back at the beginning of the class, when I told you that the thing that distinguishes the thoracic vertebrae is that they're the only vertebrae that have facets for ribs, I lied a little. C7 has a small facet for articulation with the head of the first rib. All right, let's take one more look at this just to kind of, beat this idea to death. Here's a CT scan. So it's essentially an X-ray, but we can look at an axial cross-section view. And what we're seeing here is the articulation of the different parts of the rib with one of the thoracic vertebrae. So just to orient you, what we're looking at here, we have the vertebral body, the large round or roughly heart-shaped vertebral body. We have a pair of pedicles extending posteriorly from the vertebral body. So this would be the left pedicle that I'm going over with the cursor, and then the right pedicle over on the other side. The pedicles connect the vertebral body to the lamina. So the two lamina would lie back here. And then the body, the two pedicles and the two lamina, they completely enclose the vertebral canal, which is where you'd find the spinal cord. So that that round space in there is where you find the spinal cord. Then right where the two laminae join together, you have the spinous process projecting posteriorly right in the midline. And then extending laterally from the lamina, you have a pair of transverse processes. So this would be the transverse process on the left and the transverse process on the right. So then we see a couple of ribs shown here articulating with this thoracic vertebra. And here's the tubercle out here articulating with the transverse process. And here's the head of the rib articulating with the vertebral bodies of this vertebra as well as the vertebra immediately above it, which you can't see because it's a cross-sectional view. One of the other reasons I wanted to show you this particular image, though, is to emphasize something else that's important. I think it's particularly important, if you're illustrating structures in the thorax. Notice that the head of the rib is articulating with the body, which is a little bit more anterior. The tubercle is articulating with the transverse process, which is a little bit more posterior. So that line from the head to the tubercle of the rib is actually angled posteriorly. And then the rib continues to travel posteriorly after sort of leaving the vertebra, after it's sort of independent of the vertebra, it's continuing to go backwards. And it continues to go backwards for a ways before it finally wraps back around towards the front. A lot of people, I think, assume that the ribs just extend straight out from the sides of the vertebra on the left and on the right. A lot of people don't appreciate the fact that the ribs actually go backwards quite a ways before they then begin to turn and wrap back around towards the front of the body. And one of the implications of that is the fact that the neck and head of the rib, as well as the vertebral body, they actually form a very prominent ridge that lies right in the middle of the thorax and actually helps to kind of divide the left and right halves of the thoracic cavity. And you can see that if you look at an image like this. Here we're looking into the thoracic cavity from the right-hand side. And, we've got the diaphragm down here at the bottom of the thorax. We've got the heart and some of the great vessels. You can see a little bit of the esophagus right here and a little bit of the trachea. But then notice how the thoracic vertebrae actually extend pretty far into the thorax and form almost kind of like a wall in the middle of the thorax. And then you can see how the ribs are then angling posteriorly, extending posteriorly back from the vertebrae before they finally begin to wrap back around and wrap around towards the front. All right, so we've talked about the bones of the thorax. Let's start adding some muscles on here. And for the most part, we've already removed some muscles from the thorax, like we've already detached the pectoralis major from its origin. The pec major has its origin on the clavicle, the sternum, the ribs, and the costal cartilages. We've already detached the pectoralis minor that has its origin on ribs 3, 4, and 5. But those are really considered muscles of the upper limb because the pec major and the pec minor are moving the scapula and they're moving the humerus. So they're really limb muscles. Same thing posteriorly, you've got things like latissimus dorsi, you've got trapezius, which both have part of their origin on some of the thoracic vertebrae. But again, they're really limb muscles because they're attaching to the scapula and they're attaching to the humerus. They're moving the upper limb relative to the thorax. So the only muscles that really belong to the thorax itself are these intercostal muscles that lie in the spaces between the ribs, the intercostal spaces. There are 3 layers of intercostal muscles. And I'll warn you right now, I've never been too thrilled about the naming of the layers either, and you'll see why in a minute, but we're kind of stuck with these 2. The first 2 layers make perfect sense. Their names make sense. There's a layer of intercostal muscles known as the external intercostals, which you probably can guess are the most external of the three layers, closest to the outside or most superficial. A couple of interesting features of these external intercostal muscles. For one thing, what you can see here on this picture is that the external intercostal muscles lie only between the bony parts of the ribs themselves. The external intercostals do not lie in the spaces between the costal cartilages. So they're only between the actual bony part of the ribs, not between the cartilaginous parts. The other thing that's distinctive about the external intercostals is the fiber direction. So I have to do this in a way that the Zoom folks can see me. So the different layers of intercostal muscles have different fiber direction, and you can sometimes use this to help distinguish them. So what I like to do is I imagine that I'm wearing a jacket, which would be appropriate for this time of year, a jacket that has some pockets to keep your hands warm. And so you stick your hands into those pockets here around your abdomen area. The direction of my fingers, as my fingers go into those pockets around my waist, around my hips here, that's the direction of the external intercostal fibers, right? So if I actually come up here to the thorax and bring my hands up, you see the orientation of my fingers. That's the orientation, the angle of the fibers of the external intercostals. The next layer of muscles is called internal intercostals, which makes perfect sense. A couple of differences between the internal intercostals compared to the externals. For one thing, the internal intercostal muscles actually do continue all the way around to the sternum, lying not only between the bony parts of the ribs, but also lying between the cartilaginous costal cartilages. So what that means is, if you look in these spaces between the costal cartilages, very close to the sternum, what you'll see is a kind of a shiny, transparent membrane, which is really a continuation of the external intercostals. It's not, there's no muscle to it, but the external intercostals do continue in here as just a transparent membrane. And then through that membrane, you can see the fibers of the internal intercostals, in these spaces between the costal cartilages, very close to the sternum. So you're going to be dissecting these intercostal muscles today. So you'll actually want to be looking for that. You'll want to see if you can find that thin transparent membrane, which is part of the external intercostals or continuation of the external intercostals. And then you'll be able to see the orientation of the internal intercostal fibers just beneath or just deep to that membrane. Another difference is the fiber orientation, the direction of the muscle fibers of the internal intercostals. So let's go back to my hands in my jacket pockets again. So the direction of my fingers is the orientation of the muscle fibers of the external intercostals. If I stick my thumbs out like this as I put my hands in my pockets, so my thumbs are oriented essentially perpendicular to my fingers, that's the fiber direction of the internal intercostals. The internal intercostal fibers are oriented almost 90 degrees, almost perpendicular to the external intercostal fibers. Now here's where the naming gets weird, in my opinion. The third layer of intercostal muscles is called the innermost intercostals. We can't call them external, middle, and internal. We've got to have external, internal, and even more internal. It's a little weird, but we're stuck with it. So this is a different view of the thorax. Here we're looking at the inside of the front of the thorax, as if we've cut off the ribs and the sternum and removed the whole front of the rib cage with the sternum attached, and we're looking at the inside of that removed piece. In fact, this is very similar to what you're going to do in lab today. You're going to cut off all these ribs. You're going to remove the whole front of the rib cage, including the whole sternum with it. And from this internal view, you can now see the innermost intercostals. Well, another reason why I'm not crazy about this nomenclature is that the internal intercostals, or excuse me, the innermost intercostals are essentially identical in every way to the internal intercostal. So internal and innermost look like virtually the same muscle. They lie in the same area in the intercostal spaces. They have the same fiber direction. So the innermost intercostals share that orientation like I had, with my thumbs when I put my hands in my pockets. Really, the only thing that distinguishes the innermost intercostals from the internal intercostals is the fact that the intercostal nerve, artery, and vein lie in a little plane or a little space between them. So if it wasn't for the fact that you had the intercostal nerve, artery, and vein basically traveling through a little space between these two sets of muscles, the internal and innermost intercostals would really be the same muscle. There's simply just a slight separation between them because of that intercostal nerve, artery, and vein. And you may be able to see that, maybe a little tricky on this slide, but the area that I'm circling right now, you might be able to make out the nerve there. And then there's also an artery and vein running along with the intercostal nerve. And it looks like the nerve, artery, and vein kind of disappear from view right at the point where I'm circling with the cursor. That's the point where the intercostal nerve, artery, and vein then enter this little canal, or this little space between the internal and innermost layer of intercostals and create that separation. There is one other set of muscles, one other muscle that's visible here on the inside of the thorax. It's called transversus thoracis. It looks like it kind of originates from the sternum and then radiates out towards the ribs in many different directions, kind of like the points of a star, kind of radiating out from the center. Oftentimes, this transversus thoracis is quite small and not particularly well developed in a lot of the cadavers. You'll probably be able to see it on all of the cadavers, but it's going to be more developed on some than others. Probably that big guy will have a really big beefy one, but a lot of the other cadavers may have kind of small ones. The innervation of all of these intercostal muscles is real simple. They're all innervated by the intercostal nerves. And we'll talk about those nerves in a few minutes, where are those nerves coming from. But just basically picture that in every single one of the intercostal spaces, there's a nerve that's traveling all the way around the thorax. It starts in the back, branching off of the spinal nerves, travels in the intercostal space all the way around to the front, and then it kind of disappears right before it hits the sternum. So the intercostal nerves are innervating all three layers of intercostal muscles and also innervating this transversus thoracis. In terms of function, the intercostal muscles are involved in breathing. They move the ribs to assist in breathing. Now let's talk a little bit about breathing, because it takes a minute to kind of realize what's actually happening when you inhale and exhale. Let's forget about the intercostals for just a second and focus on another muscle in this area that's really kind of the primary muscle that's responsible for breathing. That's your diaphragm. So the diaphragm has a very, very complex origin. We'll talk about it later when we study the abdomen. So you don't need to worry about the detailed structure of the diaphragm at this point. We'll come back to it later. But for now, just imagine that the diaphragm is a thin sheet of muscle that arches up into the thorax. So it's forming a big arch up inside the thorax. And if you look at the bottom of this picture, the dashed line illustrates the relaxed position of the diaphragm. And the reason that it arches high up into the thorax is because all of the abdominal organs are sitting underneath here. So you've got things like the liver on the right side of the body, the stomach and the spleen on the left side that sit under the diaphragm. And so the diaphragm is actually pushed way up into the thorax and forms this arch that extends up into the thorax. When the diaphragm contracts and the muscle fibers in the diaphragm contract, the diaphragm actually becomes more tight and flattens out. So instead of arching way up into the thorax, it flattens out, which causes it to sort of pull downward. And it literally pushes some of the abdominal organs downward a little bit, pushes the liver, the stomach, and the spleen downward into the abdomen a little bit as it flattens out. As the diaphragm flattens out and pulls downward, that's increasing the volume of the space inside the thorax. And this is one of the things that then causes the inflation of the lungs. And I have a little toy up here that I bought a couple of years ago that tries to demonstrate this. It's frankly, it's a little bit lame, but it tries. So the glass dome here, I'm gonna have to try to show this to our Zoom people too. It's actually plastic, but the little clear plastic dome represents the inside of your thoracic cavity. A lot of people, I think, are under the impression that the lungs are somehow attached to the walls of the thorax. So as the thorax expands, it literally pulls the lungs open. And then as the thorax collapses, it literally pushes the lungs and squeezes them. That actually doesn't happen. The lungs, under normal circumstances in a healthy person, the lungs should not actually be attached to the inside of the thoracic cavity. They're essentially free floating, sort of hanging freely within the thorax. Now, they're not all crumpled up like these lungs. They fill the entire thoracic cavity, but they're not actually attached to it. And you'll see that when we remove the front of the ribs today, you'll see the lungs. And you'll see that the lungs are not actually attached to the inside of the ribs at all. There's a thin potential space that separates them. What happens when you increase the volume of the thoracic cavity by simply pulling down on the diaphragm or some of the other things we're going to talk about in a minute, when you increase the volume of the thoracic cavity, it essentially creates a negative pressure inside the thoracic cavity. So there's now a negative pressure around the outside of the lungs. You've got positive pressure out here just in the atmosphere. So that just allows air from the atmosphere to just rush in and fill the lungs, so the lungs continue to just occupy the entire thoracic cavity. Then when the diaphragm relaxes and it arches back up into the thorax, that decreases the size of the thoracic cavity, essentially increasing the pressure in the thoracic cavity. So now you have increased pressure on the outside of the lungs. That causes the lungs to shrink, to allow you to exhale. So what this little thing does here, it has a little rubber diaphragm on the bottom, little rubber thing with a little thing I can get hold of in there. And I can push up and down on that diaphragm. In fact, all I have to do really is just pull down on it. And this may be a little tricky to see, especially with bad lighting in here, but you can always come up and look at it later if you really want to. When I pull down on the rubber diaphragm at the bottom, it expands the volume of the space inside the thoracic cavity. So it decreases the pressure around the outside of the lungs. There's a little hole up here at the top that leads to that little plastic trachea inside. And that allows air to then rush into the lungs and the lungs inflate. And then when I let go of the diaphragm, let it relax, then that increases the pressure in the space around the lungs. So then the lungs collapse. So I can breathe in and out. And again, I don't know if you can see it all, but every time I pull down on that little diaphragm, the little balloon lungs fill up with air. But all that air is simply rushing into the hole at the top. The diaphragm is not actually connected to it.
For was it mechanical breathing respirators?
Yep.
Is a similar mechanic where they just force air in and out?
So a mechanical respirator literally pushes air into your lungs and then pulls it back out. It's literally using air pressure to push air into your lungs and then suck it out. Because if you need a mechanical respirator, usually it means that you're thoracic muscles, your diaphragm isn't working. Especially like someone who's had an injury of their cervical spine up around level C1 or C2, had an injury to the spinal cord at C1 or C2. You remember me mentioning that the phrenic nerve is the nerve that innervates the diaphragm. The phrenic nerve comes from C3, C4, and C5. If you damage the spinal cord above C3, you lose innervation of the phrenic nerve, paralyzes the diaphragm. They can no longer expand the chest cavity. And so someone who's a quadriplegic at C1 or C2, they have to be on a respirator or ventilator that literally pushes air into the lungs and then sucks it back out again.
You not put like a diaphragm pacemaker to like just stimulate it to go, or no?
I have a picture of big like getting inflated. Anyone wants to see it?
You have one, sir?
A picture of pig.
Pig lungs?
Big star tube and then air to show how it's inflated.
That's interesting. I mean, that's an interesting idea. Those of you who are on Zoom or anybody else who couldn't hear the question, is it possible to have like a diaphragm pacemaker to stimulate the diaphragm the same way you have a pacemaker to stimulate the heart muscle? Maybe. Seems like a reasonable thing. Sounds like, I'm guessing somebody's probably thought about it. Whether they've tried it and it didn't work, I don't know. No idea. But interesting idea. So let me try to show this to the folks at home. So here's my little jar, little rubber diaphragm down here. When I pull down on it, let's see if you can see this or not. It makes the lungs kind of expand just by decreasing the pressure in the thoracic cavity around them. Anyway, so that's fun. So if you're just doing very shallow breathing, you're not exerting yourself, you don't need to bring in lots of oxygen, you can probably breathe entirely just with your diaphragm. In fact, probably most of your life, you're just breathing with your diaphragm. I'm guessing a lot of you right now, it's mostly diaphragmatic breathing. You're not like really trying to open up your rib cage and collapse it. Especially I think when you sleep, it's just your diaphragm moving. The other muscles aren't really doing anything. But if you're exerting yourself and you need to breathe a lot more deeply, then you actually need to expand the size of the chest cavity a lot more. Simply flattening out the diaphragm isn't enough to bring enough air into the lungs and then expel it again. So that's really when the intercostal muscles come into play. So the external intercostal muscles lift one rib up towards the one immediately above it. And the external intercostals, which are shown on the left side of the slide, work in conjunction with some of the muscles up in the neck, such as sternocleidomastoid and the three scalene muscles, which are going to pull up on, the sternocleidomastoid is pulling on the sternum and the clavicle, but those things in turn are then connected to the rib cage. So you can pull up on the thoracic cavity with sternocleidomastoid, and then the scalenes insert directly on ribs 1 and ribs 2. So they're going to lift up on the upper part of the rib cage. And then the external intercostals will pull the lower ribs up towards the upper ones. And that's actually going to expand the volume of the rib cage. And I have some pictures I'll show you in a minute that help to kind of explain that. Then when you want to exhale very deeply, especially if you're doing something like trying to blow up a balloon or something, you need to exhale with a lot of force. The internal and innermost intercostals actually pull down on the ribs, and they work in conjunction with some of the abdominal musculature, like the rectus abdominis in the front of the abdomen and the oblique muscles around the sides of the abdominal wall. These things all pull down on the rib cage to collapse the size of the rib cage. Now, it might not be obvious to you right away how lifting up on the ribs expands the side of the rib cage and how pulling down on the ribs decreases the size of the rib cage. It seems like Okay, so we slide the ribs up. How does that actually increase the volume? There are a couple of features, the way the ribs are oriented, that actually result in this increased volume as you pull up on the ribs. I apologize that the picture on the left was not included in the PowerPoint that I posted on my courses. I just found this and added it today. But the two images on the right, the two kind of cartoon images on the right are included in the PowerPoint. So what we're looking at here on the left is just a lateral view of the rib cage. And notice something really important about the ribs here. And if you guys have to model this in 3D, this is an important thing to keep in mind. The attachment of the ribs to the vertebrae is quite a bit higher than where they attach to the sternum in the front. The ribs actually angle downward at a pretty reasonable angle, fairly steep angle. When you lift up on the ribs, and in particular, when you lift up on the sternum, not only do the ribs raise up, but because they're oriented at this angle, they actually kind of swing forward. They swing in an anterior direction. And that's been described as a a pump handle phenomenon. So if you think of a single rib as being like on the handle of one of these old-fashioned water pumps, you see how the handle of that old-fashioned water pump is kind of angled downward when it's sitting at rest, similar to the angle of the rib as it angles down from the vertebra down towards the sternum. When you lift up on that bucket handle, or on that pump handle, it doesn't just simply lift straight up. As it lifts up, it also swings outward, away from the pump itself. The ribs do the same thing. As you lift up on them, because of the angle that they're at, the sternum actually moves forward a little bit. And by moving the sternum forward, that actually is increasing the overall volume inside the thoracic cavity. The other feature of the ribs that also helps to expand the volume of the thoracic cavity is that each rib is curved, but those curves, as the rib curves from the front of the body around towards the front, from the vertebrae around towards the front to the sternum, they're not lying in a perfectly flat plane. I was actually looking online to see if I could find a good picture of one of those cheap Halloween skeletons you can buy as like a decoration. Oftentimes their ribs will go around the body in a perfectly horizontal plane, from back to front. Real ribs don't do that. Real ribs actually dip down on the sides. And this is what's described as a bucket handle phenomenon. So you've got the ribs attaching to the vertebrae in the back, just not really visible here, but you have to just kind of imagine it. And then the rib dips down and comes back up again as it attaches to the sternum here in the front of the body. So it's like one of these curving handles of a bucket resting against the side of the bucket, against the edge of the bucket. When you lift up on the ribs, again, not only do they go straight up, but they also have to swing outward a little bit because of that curvature, the same way that handle of a bucket swings outward a little bit away from the bucket as you raise it up. So take a look at some of the buckets in the cadaver lab and confirm how that works. So really there are three things going on when you want to take a deep breath. First of all, you have the diaphragm, which is flattening out and pulling downward. You have the various musculature in the neck and the external intercostals pulling up on the ribs, which cause this pump handle phenomenon where the sternum actually moves forward as it comes up. And you also have this bucket handle phenomenon where the lateral edges of the ribs, the curved edges of the ribs, are actually swinging outward as they come up. So you can take a really, really deep breath because you can significantly increase the volume of the thoracic cavity. And here's a really simplified schematic showing something very similar to my little dome toy here. The sort of tan color in the background just represents the outline of the thorax. There's a pale blue, I don't know if it shows up as blue. Oh yeah, it shows up a lot better up there, doesn't it? There's a pale blue area, which represents something that we call the pleural cavity, which is the technical name for the inside of the thoracic cavity. And then the lung, shown in pink, occupies that entire pleural cavity, but it's not actually attached to it. So in the upper picture, the diaphragm, which is this red line down at the bottom, is flattening out and pulling downward. And then the ribs, as they're being pulled upward by the neck muscles and by the external intercostals, as they move upward, they're also moving outward. And that's increasing the volume of that pleural cavity or that thoracic cavity. So that's essentially creating negative pressure around the outside of the lungs. You've got atmospheric pressure outside of the lungs, as long as you open your mouth or your nose. And so that the air pressure outside the body is now higher than it is in the lungs. So air rushes in through the trachea, through the bronchi, into the lungs to fill them up. And then when you want to expire or exhale, you relax the diaphragm. The diaphragm then arches back up into the thoracic cavity. You pull the ribs downward by pulling down with the abdominal muscles and with the internal intercostals. And so that decreases the volume of the thoracic cavity. So that's increasing the pressure in that pleural cavity surrounding the lung. And that makes the lung smaller and pushes the air back out. All right, last thing I want to talk about in the thorax is just the blood supply and the nerve supply. So here we're looking primarily at the intercostal arteries and where they come from. Next week, I'm going to talk about all of the other arteries and veins in the thorax, including the big arteries and veins that are attached to the heart. So we'll talk a lot more about the aortic arch and the pulmonary arteries and pulmonary veins and things. We'll come back to that next week when we talk more about the contents of the thorax. But I just want you to focus on these intercostal arteries that are branching off of the aorta. So this is where the intercostal arteries are coming from that are supplying blood to those intercostal muscles in the intercostal spaces. So all along the thorax, you have these what are called posterior intercostal arteries branching directly off the aorta. One thing that's kind of interesting to keep in mind if you ever have to illustrate this, is that the aorta does not lie right in the midline. The aorta does not run right down the front of the thoracic vertebrae. The aorta is shifted to the left. What that means is that on the left side of the body, the posterior intercostal arteries branch directly off the aorta and travel right into, directly into the intercostal spaces on the left side. Over on the right side, though, the posterior intercostal arteries are still branching off the aorta, but they actually have to cross over in front of the vertebral bodies before they finally reach the intercostal spaces on the right. So they just have to travel a longer distance to get from the left side of the body over to the right, and they actually have to cross over the vertebral bodies in order to get over to the intercostal spaces on the right-hand side. We'll see something similar when we get down to the abdomen. The renal arteries, which supply blood to the left and right kidneys. The left renal artery is a lot shorter because the aorta is shifted to the left. The right renal artery is a lot longer because of the fact that the aorta is closer to the left side. So it's another important thing to think about when you're illustrating. One other thing I want to point out on here is another artery. It's not shown very clearly on here. You can only see the cut stump of it, but here's the subclavian artery. This would be the left subclavian coming directly off the aortic arch and then coming up and exiting the thorax to eventually go down into the axilla. There's a little cut stump up here, which is called the internal thoracic artery. That internal thoracic artery is going to run down along the inside of the sternum on the deep surface or posterior surface of the sternum. And we'll see that that's also giving off intercostal branches of its own. So here's a horizontal cross-sectional view through the thorax, and it's actually as if they've sort of cut a chunk out of the thorax here, and we're looking more or less down on top of this, also, you know, a little bit anterior. So it's kind of an oblique superior anterior view of this slice out of the thorax. And you see the vertebral bodies of the thoracic vertebrae back here and the spinal cord sitting right behind them. And here's the aorta, which, as I said, is shifted off to the left a little bit, off to the left side of the body. So the posterior intercostal arteries on the left branch off the aorta and go directly into the intercostal spaces and begin to wrap around in the intercostal space. Remember, these intercostal arteries are running in that little groove, that costal groove on the inferior border of each rib. On the right side of the body, the posterior intercostal arteries have to be a little longer. They have to cross the thoracic vertebrae before entering the intercostal space. Now here in the front of the body, we have that internal thoracic artery that I was just talking about. There's one on the left side and also one on the right side. These are branching off of the subclavian arteries way up high at the upper part of the thorax. The internal thoracic arteries are giving off smaller branches called anterior intercostal arteries. And if you look closely, you'll see that the anterior intercostal artery wraps around the intercostal space and it joins up with the posterior intercostal arteries. So they form an anastomosis. Right? We have blood flowing into these intercostal arteries from two different directions. Through the posterior intercostals coming directly off the aorta, through the anterior intercostals coming off of the internal thoracic. The other thing that's shown on here is the intercostal nerve. And someday I should probably get an enlarged view of this so you can see it a little bit more clearly. But I want you to start out by looking at the spinal cord as it sits in the vertebral canal, you know, between the vertebral body and the lamina of the vertebrae. So we've got the spinal cord in there. And if you look really closely, just lateral to the spinal cord, you can see the two roots. There's a ventral root, which is the skinnier one that's closer to the front. And then you've got the dorsal root with the enlarged dorsal root ganglion on it. These are then exiting the intervertebral foramina. And immediately after the spinal nerve exits the intervertebral foramen, it splits into a dorsal ramus and a ventral ramus. The dorsal ramus is going to immediately turn posteriorly to go to the deep back musculature, the erector spinae and multifidus and all the other little deep muscles. Plus, it's also going to be a sensory nerve to some of the skin here in the midline in the back. So that's the dorsal ramus. The ventral ramus of the spinal nerve just changes names to become the intercostal nerve. So an intercostal nerve is exactly the same thing as the ventral ramus of the thoracic spinal nerves. All right, one last picture. Again, this is going to look kind of similar to what the front of your chest is going to look like after you saw it off and remove it. And all I wanted to show here is the anterior intercostal arteries branching off of the internal thoracic. So there's our subclavian arteries. going up out of the thorax and crossing over the first ribs to become the axillary artery eventually. And then there's the internal thoracic artery branching off of the subclavian, running down along the inner surface or the deep surface of the sternum, right about where the sternum meets the costal cartilages. And then that internal thoracic artery is giving off the smaller anterior intercostal arteries that run through the intercostal spaces. And they are accompanied by the intercostal nerve and the intercostal vein as well. So there's actually an intercostal nerve, artery, and vein running in that costal groove right along the inferior border of each rib. All right. Question?
Times when I do really like cardio stuff.
Real
I feel
cardio
like-
stuff.
I feel like some pain or like the false rib or like the cartilage. It's like, is it because of bone or because I'm teaching a nerve?
Yeah, so you're feeling that like down here, like where the costal cartilages are, you said? I suppose it could be a cartilage issue. There is a condition called costochondritis, which is just an inflammation of the costal cartilages. Although that would have usually, resulted from some kind of inflammation or injury to the costal cartilages. I don't know if you've ever injured that area. The other thing is it almost sounds kind of like just a muscle cramp. I know when some people, exert themselves a lot, they get like abdominal muscle cramping. Yeah, that makes.
I have a question about like the heart and the lungs.
Okay.
With the lungs expanding to fill the space because of the diaphragm moving.
Yep.
Wouldn't that also put pressure on the heart?
Not really, because you're expanding the overall volume of the thoracic cavity. So any expansion of the lungs is simply filling the increase in volume of the thoracic cavity. So the lungs are not compressing medially to put pressure on the heart. The lungs are expanding inferiorly with the diaphragm. They're expanding laterally as the thoracic cage enlarges, but they're not expanding medially, where they would actually put any kind of pressure on the heart. So the heart just keeps beating and doing its own thing, and it's not affected by the lungs at all. All right, I'm going to just pause the recording or stop the recording and stop the share here. Hang on one second. But we got plenty of time, so I'll be happy to field other questions. Actually, I'll leave the Zoom on in case anybody, maybe I'll stop sharing and stop recording, but